Today we'll be talking about infertility. So our overview is that we'll look over some of the diagnostic criteria for labeling a couple as being infertile and some of the demographics behind that. And then basically we'll go through what the evaluation would look like for men and then for women. And then we'll look at some prevention strategies and just general education, health education and promotion around promoting fertility. And finally, we'll look at treatment options. And for the purposes of this lecture, I'm primarily having treatment options focus around things we can do for women when there isn't necessarily a clear etiology behind what's going on. So a lot of different things can lead to infertility. So we'll look through how we can initially do that assessment. But for example, if their thyroid is imbalanced and that's why they're infertile, we're not going to go through thyroid management here, that sort of thing. Without further ado, let's get started. So diagnostic criteria for infertility, it would be the inability of a couple to conceive after 1 year of regular intercourse. Now, the caveat to that is if a woman is over 35 years old, then we can call it 6 months rather than a year, basically considering that we might not have as much time to wait, and time becomes a little bit more of the essence. But for less than 35 years of age, we would say a year regular intercourse without conceiving would be worth considering them to be infertile. And ideally, we see them before this point. Certainly, if a couple's been trying for 5-6 months, I would love to see them by that point so that at the very least we can start to talk about cycle changes and that kind of thing. And so that we don't get to the point of a year, but as far as having more of an aggressive workup, you'd think about starting that at about a year. So primary means this couple hasn't conceived before, whereas secondary implies that one or both of them have had a child in the past and then now they're having trouble. So sterility then is the intrinsic inability to achieve pregnancy. So that could be due to a diagnosis they have, like cystic fibrosis, or that could be due to having had surgery, etc. So demographics for the U.S., these are from 2013. You can see here that, so the red here would be 1982, and then as we get to the lightest, that ends at around 2010. The general trend then with each of these age groups is that infertility has become progressively less of an issue. So this is ages 15 to 24, ages 25 to 34, and then ages 35 to 44. So certainly you can see that there is a direct correlation with age. This study that was done here accounted for about 22,000 women. It was done from 2006 to 2010, and then the response rate was about 75%, so pretty good. Other findings from this study, they found that for women who just had difficulty getting pregnant, not reaching that full diagnostic criteria for being infertile, that number was about 11%, whereas infertility was in about 6% of women in this study. And that really, I see that number range quite a bit, even from textbook to textbook and study to study, ranging anywhere from 7 to 28%. There was no difference in infertility when they accounted for education level or poverty level or income. So I thought that was interesting. Clear positive correlation with age, as we've already seen. And then among races, there wasn't a whole big of a difference, but Asians were just slightly less likely to struggle with infertility. So we've just recently gone over birth control, and when we think about birth control, we're contemplating how does fertility happen in the first place. So we need to have a sperm that's able to get up to the fallopian tubes, so that would be one piece, right? We need an egg that's capable of ovulating and getting that egg into the fallopian tubes. So women who aren't having regular menstrual cycles, that would also imply they're not regularly ovulating. So we know that once a woman ovulates, that's when the ovary gets that 14-day expiration date of releasing progesterone, and then at the end of that 14 days, that's what's causing a woman to have her period. So if she's not having her period, that's implying that we're not consistently ovulating. So that's one piece of that. And then when you think about fertility decreasing with age, we consider if ovarian reserve is decreasing. So the number of eggs that are in her ovaries are going down, but then also how responsive are they to FSH. So considering ovarian reserve within that dynamic as well. And then transport. So part of that is the sperm, right? So say a woman's had a LEEP procedure done on her cervix because she had cervical dysplasia. Well, maybe there's adhesions on her cervix now that are such that the sperm can't get up through her cervix in order to find the egg. Or maybe there's fallopian tube scarring secondary to her having had chlamydia 2 or 3 times, and they've left scarring in her fallopian tubes that make it hard for sperm to get up as well as for the egg to be carried down. So multiple aspects in a person's history can influence that transport component. Or maybe she was born with some kind of a uterine anomaly that would influence that as well. So that's something else to consider. And then implantation. So once the sperm has found the egg, how likely is it that that egg is able to implant? Is there uterine scarring, for example, or thinking about anomalies again? Is there something about the shape of her uterus that would make it hard for a baby to implant? Okay, so throughout the rest of the presentation, pretty much everything we're thinking about can get boiled down to those 4 things. And when you're evaluating a woman or a couple, those are the 4 pieces that you're wanting to hit. Is she ovulating? Do we have sperm that's mobile and capable of getting up there and has all of the pieces it needs in order to make the journey? Does her history have components that would make transport trickier? We can do imaging to check in on transport aspects and implantation aspects as well. Okay, so let's think about males. So a woman comes in, and oftentimes it can be hard to think about bringing the man into this scenario. Sometimes men are right there with women and ready to go. But given that 25 to 40% of infertility cases can be due to male causes, it's important that this is really something they're both exploring together. And isn't just something that we're just evaluating the woman and going from there. So. And certainly if they both come in and one of the 2 of them has a significant piece in their history that automatically would lead you to think that that's going to be our primary cause, then you could certainly start there. So if a woman's coming in with PCOS and only having 2 periods a year, then certainly let's start there. But considering that it could be either of them. Most often it's due to testicular pathology, which is where our sperm is made. So that would be important, right? So things we're thinking about for men, what is their general health like? Do they struggle with any issues like erectile dysfunction or low libido? Any history of any major infections, such as sexually transmitted infections or mumps that can affect sperm? Genital trauma, so I don't know, maybe there was a bad horse riding accident when he was 10 or something like that. So thinking about genital trauma, surgical history, any hernias, testicular or varicocele surgeries, those would all be important to ask about, as well as congenital abnormalities. Maybe at birth testicles weren't descended, but within a year they were descended. You know, that those sorts of elements to it, somebody's history can play a role here. And medication as well. So what kind of medications are they taking? Are they using any street drugs currently, and have they in the past? Alcohol, tobacco, caffeine use, all worth asking about, and can all play a role. For instance, marijuana would decrease sperm motility. And then certainly any family history that would be related to infertility would be important as well. So physical exam for men then, and just as a rewind, as midwives, our scope of practice can include caring for men and evaluating men within the context of infertility and STIs. Now certainly it would be your choice if you were to choose to directly evaluate and treat men under your care versus just having them go see their primary care provider. So that would be your choice. And probably the majority of midwives I know would do the latter, but just to be aware that it would be within your scope. So hormonal abnormalities on the physical exam, are there any changes to their hair pattern, gynecomastia, or any kind of nipple discharge, that kind of thing. And then looking at the genitalia, development, bilaterally descended testes, and then evaluating if there's a varicocele. So varicoceles, they're in about 15% of the general population, but for infertile men, you see them in about 40% of the population of men that are struggling with infertility. So basically, think of it as like leaky blood vessel valves that lead to dilated veins and then backflow of blood. So I've heard it described as looking kind of like a bag of worms. So you can see here, this is what a varicocele would look like. And basically the treatment would be a varicolectomy. So it's a dilation of the internal spermatic vein, and the thought around how it's influencing infertility would be that it's increasing the temperature, and we know that the testes are intentionally outside the body because if they were inside the body, then it would fry and kill our sperm. So we don't want to cause any injury to the sperm, so that's why they're outside the body, but having this backflow of blood increases the temperature within the testes. We also think that, we don't totally understand it, so that's one thought around it. Another thought is that it changes the renal and adrenal waste concentrations to have the backflow, and that also affects sperm development. So abnormal blood flow can also interfere with testosterone concentrations. And then basically, subclinical varicoceles, you might not be able to see them on a physical exam, but if you were using ultrasound or venography for evaluating them, then you might be able to detect them that way. So that would be considered a subclinical varicocele. And so basically, we would still do a semen analysis either way, and then if the sperm counts were found to be low, then that would be worth moving from there to doing a varicolectomy. So if sperm counts are low, then we're going to take action. So again, we see that it is in 15% of the general population without it being a big problem. And certainly men that are having issues, it's not as though this is the only thing that can be an issue. And then if they have a varicolectomy, it's worth waiting a bit to do another semen analysis, because it can take even up to 6 months for the sperm levels to get back up to what we would consider a true baseline. So know that it's not an immediate fix, basically. Okay, so semen analysis. So we do a brief physical exam, and then really this is our top guns for checking men off the list. There's not too many factors to think about for the guy end of it. So we're going to do a semen analysis, and then if this is normal, we can basically write this side of it off, assuming they're not having any issues around sex with being able to get the sperm into the woman. So if that's fine, and we know that what it's containing is fine in semen, then we're good to go. Okay, so if something comes back abnormal on the semen analysis, then we need further evaluation. At this point, you could refer, or you could, well actually, before you would consider referring, it's worth repeating the semen analysis in a month to confirm. So that's perfectly fine. So start there, repeat it in a month, and then the next piece up for labs would be to check in on testosterone, FSH, and LH for the men. And then you could consider endocrine issues, urological issues, genetic causes. At this point, I would generally refer. Yeah. All right, so there's our semen analysis piece. So again, if that checks out, then we can basically check the man off the list and focus more on the woman. And this is what a semen analysis is looking for. So they want to see what our sperm count is looking like. Over half of them need to be able to have good motility. And then for volume, we're expecting 2 milliliters or more. Morphology, there's 2 different criteria. I most commonly see clinics using the WHO criteria, which is that at least 30% are normal. So really, if you take a glance here, the sperm are not perfect. Only half of them have to be able to move, and only 30% of them have to look okay. In order for us to be fine. And then we want to see that the pH looks appropriate, because that can affect how well they do as well, right? And then that we wouldn't expect many white blood cells. So that's what they're looking at. I actually know a couple practitioners who check this all themselves, though I have yet to meet a midwife who does that. I do know a couple midwives, I haven't thought to ask them, but I do know a couple midwives who specifically work in fertility clinics. This is basically what they're doing every day. And I wonder if they do this. I'm not sure. Okay, so female infertility then. We're thinking about ovulation, which alone accounts for about 40% of infertility issues among women. So thinking about the ovulation factor, we're thinking, do they have a history of oligo or anovulation where they're not having a period very often? So that would be one thing to think about. That's probably about 35% or so of the ovulation factor. And then do they have a low mid-level progesterone? So that would be a way to check in on if they are ovulating. So if they're ovulating, we're expecting that halfway through the second half of their cycle that we're getting a high progesterone level. So things like PCOS can influence that. And then for the transport factor, thinking about the cervix, are we able to get up through the cervix? Again, malformation, malpositioning, cervicitis, any kind of bacteria in that area is going to cause irritation and make it more difficult for sperm to be able to get up. Yep, so infections will do that, and then any kind of injury. So cervical stenosis, any kind of cervical mucus abnormalities, having a history of LEEP or cryotherapy, that kind of thing. And then implantation, thinking about the uterus, so structural, again, fibroids, polyps, adhesions, congenital deformities, endometriosis, and then just repeated implantation failures. And then thinking about even just the tubal factor going back up to transport. Endometriosis, do we have bits of endometrium that are growing and forming in different areas and can even cause blockage? Are there pelvic adhesions? Do they have a history of pelvic inflammatory disease that could have left scarring in their fallopian tubes? Hydrosalpinx would be another possibility here, and I can show you that when we get to one of those slides coming up. So not to belabor this slide, since I hope when you see this it feels like you could easily draw it in your sleep. But in terms of how this can be helpful for us when we're drawing labs, we know that FSH is helping all those follicles get growing early on in the first half of our cycle, and when there's FSH, it's releasing estrogen, right? So more and more estrogen is being released, and as estrogen starts to really get going, being released by the follicles, it kind of triggers the eggs to slow what they're doing down, and basically just the final last one really kicks off. But estrogen has a negative feedback for follicles continuing to grow. So as some of the follicles get bigger and bigger and bigger, estrogen that they're making slows all the little ones down, and then we just have our graphene follicle that ends up being released, right? Because I know this is all review, so I'm sorry if I'm hitting it too hard here. Okay, and then we know we have LH that's going to spike here, so that'll come into play when we're thinking about labs. And then we ovulate our one egg, and then because we've ovulated that egg, instead of the follicles releasing estrogen, these follicles become the corpus luteum that's releasing progesterone. So then you see this progesterone, and we still have some estrogen, but we know this is progesterone dominant. So we have progesterone that's being released, and then eventually this starts to fall apart and just kind of disappear and get absorbed into the ovary. And as that really drops, that's what's going to trigger us to have a period. So this is our reassurance that we are going to have a period. So then how this comes into labs for infertility is if you want to see that your ovary is capable of making eggs in the first place, then what you want to do is check FSH and estrogen at about day 3 of their cycle. So they get their period on day 1, 2 days later they come to the lab and you draw their FSH and their LH, and that gives us an indication that their ovarian reserve is good. So there are eggs there to be grown. And then the other lab that you'll particularly find helpful would be a mid-luteal progesterone. So if you're drawing labs around this point after they've had a period, and your progesterone is practically nothing, then we probably haven't even ovulated. So that would be one of our ways for us to assess if we're even ovulating. If you can't ovulate, then you can't have a sperm find an egg and get pregnant, right? So those are our 2 helpful labs when thinking about the menstrual cycle. Okay, so let's think about how we would conduct a history for a woman and a review of systems for a woman who's struggling with infertility. So menstrual cycle characteristics, we basically got over that, but how often is she having a period? When she has a period, how many days does it last? How old was she when she first got her period? So getting a full menstrual history is important, especially if she's not having regular cycles. And then pubertal development, that's also influenced by how her brain has been guiding that process for her, as well as the reaction her ovaries have had to those hormones, like growth hormone from her pituitary gland. And the contraception history, is this a woman who was on the Depo-Provera shot for 5 years and is now 6 months post using that? I wouldn't be surprised at all that she's having a hard time getting pregnant, versus, say, a woman who was doing natural family planning for a long time and now it's been a year since she's done that, has a very good sense of her cycle if she was using that as contraception, but is now finding that she's not getting pregnant. So what has she been doing for birth control, and how might that influence her current situation? Sexual history, this can be helpful for thinking about if she's been at a high risk for sexually transmitted infections. Has she been regularly tested throughout her life, that kind of thing. As well as thinking about if maybe she's married to a truck driver who's in town maybe 2 weekends a month or something like that. So that would be important to think about her current situation for how that could be influencing just the number of times there's a possibility. So again, thinking about the definition being that they've been having regular intercourse for a year and aren't pregnant. Would her current situation qualify as having regular intercourse? Pregnancy history. Has she had any ectopics that can cause uterine scarring, that can influence the tubal factor with transport for both the egg as well as the sperm? Is this a woman who's 38 and on her second marriage where they've both had children before? Or is this a woman who is 22 and is trying for the first time, and yet it's been almost 2 years with no success? So you can see how the pregnancy history can play a big part in understanding her current situation. Any prior infections, particularly gonorrhea and chlamydia, but really any kind of infection in the vagina, if it's been recurrent, can lead to a hyperinflammatory state that can make it more difficult to conceive. So asking about that. And then medical history, particularly thinking about diabetes, thyroid disease, PCOS, endometriosis. All of those can have an impact on fertility. Surgical history, especially any kind of a pelvic history. So if she's had C-sections before, or if she's had an ovary removed, or say she had just the tube removed and not the ovary. We talked about in reproductive physiology. If there's 2 ovaries there, but only one of them has a patent tube, then her ovaries are going to be taking turns every month. But that would cut her fertility in half. Whereas if they'd removed one of the ovaries, then that other ovary would pick up the slack and actually ovulate every month. So understanding her pelvic history. And then Pap history, especially with treatments, because that can influence our cervical factor for transport. General health, diet, exercise, BMI, stress. I don't want to underestimate that bullet point, and that's a huge part of how we can come around women and help to boost their fertility. So really having a thorough understanding of where they're at on that front. Diet diaries, etc. would be part of a full workup. And then what kind of medications is she taking? Street drugs, I think especially of marijuana, alcohol, tobacco, caffeine use. All of these have an influence not only on fertility, but also on spontaneous abortions. So if we do have an egg that implants, what is the likelihood that we can keep it there? So those would all be things to ask about, and then would be the first things we would want to modify for women. So those last 2 points are good for getting an assessment, and then are definitely going to be part of our... Okay, so then for our physical exam, that'll include our BMI and our distribution of body fat. and checking in on her thyroid. So we're palpating it, and then we'll probably be drawing labs as well. Breast formation, any galactorrhea, hair pattern, thinking about hirsutism especially. That's oftentimes linked with PCOS, but hyperandrogenism, whether or not it's linked with PCOS, can be related. Or virilization would be a thought there as well. So thinking about, hormones that women are on impact a lot of body systems. So checking in on those. Acanthosis nigricans, so seeing darkening on the back of her neck, for example, would show insulin resistance. So that would be something to be looking for, again, thinking about PCOS. And pelvic exam, so just doing a full pelvic exam and making sure nothing stands out to you on that front. Great. Okay, so hirsutism, I'll try to make this one a little bit bigger would be helpful. So this is nothing new, I don't think. Okay, so upper lip, so you can grade it. So 1, 2, 3, 4 for each of these categories. So different places you can see it. Upper lip, on the chin, chest, upper abdomen, lower abdomen, arms, thighs. What are we missing down here? Upper back and lower back. Okay, so that's all of our areas, and you can see you can score those up. And then 9 body areas possessing androgen-sensitive pilosebaceous units are graded 0. So no terminal hair to 4, which is obviously what we've seen here. So normal would be 0 to 8. So if you're seeing more than 8, then that would be a reason to have PCOS maybe higher on your differential. And then there's an example of acanthosis nigricans. Okay, so that's our physical exam, and then for labs, we can go multiple directions. Certainly you can do a full panel like this. That would really be appropriate. If one piece already really stands out from her history or her physical exam that is leaning you in one direction, then that would be fine to start there. But this would be a full workup. So we're doing gonorrhea, chlamydia, and doing a wet prep, realizing that any kind of bacteria present can irritate the endometrium. We can do the FSH and the estrogen. So estradiol is E2, right, on cycle day 3. So if you see CD in anything related to infertility, it's talking about cycle day. So we'll do that to check on ovarian reserve. We can also do a mid-luteal progesterone as a helpful indication on whether or not we're ovulating. Prolactin, certainly if we had high levels of prolactin being excreted from our pituitary gland, then that can keep us from ovulating as well. So same for like breastfeeding women, they have high prolactin levels, and that helps to serve as a birth control for them. But in the same way, say there was a pituitary tumor or something like that going on, if there were high levels of prolactin, then that would be discouraging ovulation. Thyroid imbalance can certainly lead to infertility, and that can be common with women, so that's a good place to start as well, and rule it out. Anti-Mullerian hormone is also checking for ovarian reserve. Basically, anti-Mullerian hormone in the body, it's made by the granulosa cells of small follicles that are forming. So an advantage to doing AMH versus doing like the cycle day 3 for FSH and E2 is that because it's made by small follicles, it can really be drawn at any time in her cycle. So AMH is not cycle dependent. And sometimes if you have women who are hardly ever having a period, it's like, well, I don't know when to draw her mid-luteal progesterone. She's not having a period. And the same goes for cycle day 3, which you could consider doing like an ultrasound and looking at the lining of her uterus. That can also be helpful on that front. But basically just be aware that AMH is another way for you to check for ovarian reserve. And you don't have to draw it at any particular time. So that's the benefit there. And then certainly checking her insulin and blood glucose levels, especially as that can relate to both diabetes, which could have an impact, as well as PCOS. You might find something there. And then the last 2 would be testosterone levels. So, okay, great. So then a little bit of review here. We want to make sure that she's ovulating. So different ways to do that would be checking that mid-luteal progesterone. so roughly the 3rd week of her cycle, and you want it to be over 2. Home LH predictor kits would also be helpful for confirming that a woman's ovulating. Cervical mucus, helping her check her own cervical mucus, as well as basal body temperatures. So all of those components can help provide reassurance that the issue around her infertility isn't that she's not ovulating. So LH predictor kits you can see here. They work similar to like a pregnancy test, so it's like peas on a stick, and then the 1 line means you're not pregnant, 2 lines means you're pregnant, right? So in the same way, 2 lines here would mean we're having high levels of LH. So if you think of the threshold here, any of the days in this realm would indicate that she has an LH surge. So if she has an LH surge and it's found on the LH predictor kit, then we're expecting that she'll ovulate in the next 12 to 36 hours. So advice here would be perhaps have sex 3 consecutive days, or if you're concerned about low sperm count, then she could have sex every other day so that each time she has sex, the semen would be carrying higher numbers of sperm. So that would be our target time to do that. And then certainly if we can already have sperm up there waiting, we know that sperm can live up to 5 days, right? So again, if we're having trouble getting pregnant, we say sperm lives up to 5 days. If we're trying to avoid pregnancy, we say sperm lives up to 7 days. So I don't know how sperm managed to decide how long they're going to live based on if we're wanting a baby or not, but it seems to work that way, right? Okay, so then something else that we can do, this is thinking about assessing ovarian reserve. So what you can do is the Clomid challenge test. So Clomid is encouraging your body to make more follicles, but if we don't have very much ovarian reserve, then no amount of doing that is going to be helpful. So what we can do is we can draw FSH and estradiol on day 3, right, which is helpful information in and of itself, and then we can have her take Clomid days 5 through 9, and then repeat the FSH and E2 draw on cycle days 10 or 11, and then that can give us reassurance that her ovarian reserve is good, and then it can also give us reassurance that she would respond well to Clomid. So you could make, if you were doing a challenge, I would make your Clomid dose like about 100 milligrams. Okay, so that's something else we can do there. And then let's just think through a couple of the different types of imaging that we could do to evaluate women. So one would be ultrasound that can help detect our endometrial lining, as well as looking for ovarian cysts, polyps, uterine anomalies, fibroids, etc. And all of these we'd ideally like to do early on in a woman's cycle. So, well, if you're going to be checking for, if you're going to check for endometrial growth, then doing it serially would be more helpful. But in general, if we're just wanting to get a good once-over of the female anatomy that's present, either ultrasound or the hysterosalpingogram early on in the cycle would be more helpful. So the hysterosalpingogram basically what it is an oil-based dye would be injected up through the cervix into the uterus, and then it would continue to travel through the fallopian tubes. And so after that happens, then an x-ray would be taken. So that's what I have a picture of here. And what the x-ray then tells us, first of all, would be the patency of the tubes. So you can see in this one, the dye is present. So her vagina into her cervix here. This is her uterus, and then we can see it getting all the way to the ovaries. All the way to the ovaries on both sides. Whereas on this side, it clearly goes through one, whereas on this side it's blocked. So this might be your woman who has a history of any kind of pelvic surgery where maybe something got nicked and then there's adhesions, or perhaps she has a history of chlamydia 3 times or something like that. But we can also be checking for congenital deformities this way. So what does the shape of our uterus look like? And then the patency of the tubes. So that's basically what that would be helpful for. And then a laparoscopy is going to be quite a bit more invasive. This would be done kind of like outpatient surgery. So she'd be under general anesthesia, but this can be used to treat adhesions and scarring, as well as some tubal disease, or say with endometriosis, they could remove some of the adhesions from that as well, and some of the stromal tissue. So, so that would be a possibility as well. More of a treatment than an evaluation, but it can be a little bit of both. Might be able to find something and then fix it while you're still inside. So again, outpatient surgery, typically under general anesthesia. Okay, so that's our imaging. So I'm not going to get into how we would treat all of these, but just to be aware that once you've drawn a bunch of labs, if you're finding things that are abnormal, here's what's kind of on your differential. So premature ovarian failure. Maybe the AMH or the anti-Mullerian hormone that we drew was really low. Same for the 3-day FSH-E2. This could be a woman who is older or where her ovaries are just giving out early. But basically you're testing around evaluating for ovarian reserve. Failing that testing, like a Clomid challenge, would put premature ovarian failure high on your differential. She might also not be having a period anymore, that kind of thing. She might even be having symptoms of menopause even though she's only 35. So then PCOS would be pretty high on your differential, especially if she's not ovulating, from what you can tell. So probably a lot of your labs are going to be off. And again, I'm not going to get into all the logistics around PCOS here, but your physical exam, you might find hirsutism. Your ultrasound, you might find multiple cysts. So having polycystic ovaries certainly would put PCOS higher on your differential if you found those on ultrasound. Okay, so then hyperprolactinemia I already kind of alluded to earlier, but you might find that your serum prolactin levels are high, and then you also might find that your FSH and LH is low, which we would expect. So prolactin would directly work on the ovaries to say, hey, don't make an egg, such as, I'm breastfeeding, we don't need an egg right now, right? So that negative feedback loop there could be in effect. So check for that, and then hypogonadotropic hypogonadism, and each of these is outlined in your textbook pretty nicely too, so that's a good place to go as well. But for thinking about hypogonadism, low levels of estrogen, typically you're going to refer your physical exam. She might not look fully developed. And then gonadal dysgenesis, thinking that can be like a broad term for genitalia abnormalities, so Turner syndrome, that sort of thing. And then any kind of adhesions, fibroids, endometriosis, things that show up with your diagnostic imaging. All of that could be causes for women for what's going on. But if we're finding that maybe our day 3 FSH E2 is low, but with Clomid it responds nicely, then we've got ourselves a treatment right there. So, and treating any of these issues could definitely help as well. So 20% of the time there's several factors that might be suboptimal, but basically most women are going to fall, or most couples really are going to fall under having unexplained infertility. So you can consider it unexplained when the following pieces have been met. We have a normal uterine cavity, so we've done some kind of imaging around that. We have bilaterally patent tubes, again related to our anatomy. And then we have normal semen analysis, so that's our guy component, and then evidence of ovulation. So if all of those are in place, then we can chalk it up to we don't know what's going on, but there's things that we can do. So treatment options. First step would be promoting fertility and cycle awareness, which is especially helpful if we're able to rope in women before we hit that year mark. So all of that's fairly self-explanatory, but everything we were doing for natural family planning to prevent pregnancy, teaching them all the same education around that in order to promote pregnancy, especially with cervical mucus. But basal body temperatures can be helpful here as well. If women are wanting to get a good sense of around what time every month they're ovulating. So certainly once we have that basal body temperature rise, then we've already missed our window. for having sperm already up there and waiting, but that can certainly be helpful for gaining a better understanding of cycle awareness. We can use medications like Clomid, which we'll get into, and then intrauterine insemination is an option. And that might sound intimidating, but that is absolutely something that you can do. The dexterity around it is basically the same as putting in an IUD. You're just putting a little thin tube up into her uterus and then injecting the sperm into it. So that is definitely something where if this is of interest to you, you could take women all the way up to the point of IUI. And then last but not least would be assisted reproductive technology, oftentimes abbreviated ART. So that would include in vitro fertilization as well as intracytoplasmic sperm injection. So promoting fertility, this is just kind of a nutshell slide here, but for men, thinking about minimizing hot tub use, so the hotter their testicles are, then the more likely we're frying sperm. So that's what we've got in our head. And the more we're compressing it, the same thing. So both the physical pressure as well as putting it closer to the body, which heats it up. So biking can cause pressure. Briefs and constricting pants can cause pressure. So this can really even mean changing the kind of underwear men are wearing. Laptop use on the lap. So if you're using a laptop, not having it directly on the lap, again, thinking about heat. And then consider taking zinc and vitamin C every day. That can improve sperm motility. And then for women, really wanting to optimize their healthy weight. Huge difference. And this is what we're good at right here. We can definitely be promoting fertility and be first line for women in promoting their fertility here. So talking about nutrition and exercise, giving up alcohol, cigarettes, and drug use as long as we're in this period. Well, most of that we could probably just give up for life. Okay, and then reducing stress. Everybody's heard a story about somebody going through all the work of adopting, and then as soon as they adopt, then they get pregnant because all that stress is gone. So, so making sure we're evaluating that and helping them brainstorm ways to decrease stress in their life and to increase relaxation in their life. And then consider having them go to counseling and make sure they're taking prenatal vitamins so that we are on board when we do get pregnant. And for both men and women to minimize lubricant use as much as possible. So for medications, these are all addressing the ovulatory factor. So if we don't think we're ovulating, this is the direction we're going to go first. So our PCOS women will start with working on weight loss if that's a concern. And once we're in a good place there, if we're still not pregnant, we're still not having regular cycles, or sooner based on what your relationship is with a woman and what that looks like, this is what we're doing. So Clomid, basically, remember that I said that as FSH works on those growing follicles are releasing estrogen, and then estrogen's going to turn around and stop FSH from being released, which stops our eggs from growing. So the more estrogen we have, the more slowed down that those growing follicles are going to get. So what Clomid does then is it blocks at that estrogen feedback, so the body makes more FSH. Okay, I'm going to say that again. Clomid is blocking the estradiol feedback to the brain. It's releasing FSH so that the body makes more FSH. So because of that, we might end up having more than one Graafian follicle, but we're much more likely to ovulate in the first place, which is what we're doing. So if we have more than one Graafian follicle, we're thinking twins, triplets, etc. So with Clomid, on average, it's about an 8% chance of twins. Okay, so an example of how you could use it would be that they take Clomid. You could do 50 to 100 milligrams, and then you could have them take it on days 3 to 7 or days 5 to 9. Doesn't really matter, just pick one and stick with it. So they would do it for that point, and then the assumption being that that would help prompt the body to make more FSH so that they're more likely, the ovary is more likely to release an egg around day 14, if it's a 28-day cycle, that is. Okay, and you could do something similar to that with letrozole. Letrozole basically works in the exact same way. So it tricks the body into thinking that you need more estrogen, basically is what it's doing. It's blocking estradiol production. So the body thinks it needs more estrogen, which in turn is going to prompt more FSH and more growth. So something to consider with that is if we're blocking estradiol production, we might have side effects like hot flashes, night sweats, vaginal dryness, depression or mood swings, so emotional lability on the flip side of that, and then bloating. So similar symptoms to menopause, just to be aware of that. And then treating pituitary and or thyroid conditions is needed. And consider laparoscopic ovarian drilling for PCOS. So that would be so a laparoscopic surgery, and then basically it's like if they can poke little holes into the ovaries, then we're going to be more likely to be prompted to ovulate. So that's fairly invasive, and I know at least for me I probably would have referred somebody on before we would get to that point. But all things to consider if the issue is an ovulatory factor. And then we have intrauterine insemination. So this would be more mild to moderate issues with infertility, especially thinking about it if we know that part of the reason we're having trouble is the cervical factor. So this is our woman with a LEEP procedure, or maybe it's a guy who's having issues around sex that are making it hard for us to be able to get sperm into the vagina. So these would all be an option. Those of you who are really hoping to be available to women and men in the LGBT community, then this can certainly be something that you could offer and provide. And again, you can see here that there's just this little thin tube that goes up into the uterus and releases sperm. So it could be sperm from the male partner, or it could be sperm that they've gotten from a sperm donor that they know. And I think if that's the case, I would definitely recommend that you give them options for having that male tested prior to having his sperm be utilized, which can sometimes be tricky if it's a family member or whatnot. But if they go through a sperm bank, then you know that everyone's been really well tested. So that's worth thinking about as well. And then basically, if it's a sperm bank, I mean, I've had catalogs even show up to our office where you see a picture of a guy when he was a baby, and then you basically have his resume and a snippet next to it. So this person is a neuroscientist, et cetera, et cetera, et cetera. This is his race, this is his blood type, etc. If you're going to go through a sperm bank, you may as well have the Rh positive negative thing be in your favor. If you have an Rh negative woman looking for a sperm donor, you may as well have her find somebody else who's Rh negative. Yep, and then it would be mailed typically to their house in a container that keeps it really, really cold. And then they would basically keep it until she reaches, basically the LH predictor kit is saying, yep, it's time, it's time, it's time. And then she would come to you, and then you would do this part of it with getting the sperm up into her uterus. So if that's something that's of interest to you guys, I'd really recommend that you pursue it. I know at my clinic, we've actually got a couple different providers that offer it. And it's been a great way for us to offer the LGBT community, especially, a safe space. So that's an option as well. And then assisted reproductive technology, this is our in vitro and our ICSI. So in vitro would be like unexplained infertility. We've already tried IUI. Maybe we have blocked fallopian tubes. So if our fallopian tubes are blocked, you know, if we found that on our hysterosalpingogram they're not patent, then IUI isn't going to work because there's no egg for the sperm to find, right? So that would be an example of doing in vitro, where we're already putting in, this would be the petri dish where you put the sperm in with the egg in the petri dish, and then a bunch of eggs end up fertilized, and then you would put typically 1 to 3 embryos per cycle, and that would give you a 15 to 35% success rate. So that's going to depend on the provider for how that's done. But at this point, you would have referred on. And then, so that would be in vitro, would be the petri dish. And then intracytoplasmic sperm injection is when you have like a poor semen analysis or IVF failure, or maybe there's been a vasectomy, inability to have an erection or ejaculate, so those male factors. This would be an option as well. And this here is a picture of intracytoplasmic sperm injection. So you're picking exactly what you want and then taking it straight into the egg here. All right. So I think it just helps to have kind of a rough idea so that you can provide a little bit of counseling for women, and then at that point you're referring them on. And it depends a little bit on your clinic and the other midwives that you work with for how much you end up doing around infertility. Certainly you could do a fair bit of this, whether that's Clomid and IUIs, and then if that piece of it's not working, then sending them off, or at least doing that full initial assessment. And then if the cause for their fertility feels a little bit over your head, then at that point referring them on. And then certainly you can have them come right back to you once they are pregnant. But like if you're in a small practice where you're around quite a bit, you could certainly be the main person tracking someone. Whereas other times it can depend on the degree of comfort that the other midwives in your practice feel with managing infertility. There's oftentimes kind of an agreed upon point where everybody gets sent off if more help is needed. But usually more help isn't needed. Usually having a good sense of your cycle, having maybe a little bit of weight loss, thinking about more seriously about your nutrition and decreasing caffeine and alcohol, and not smoking if that's an issue, and that in and of itself makes all the difference. And we haven't even gotten to Clomid at that point. Okay, so just final things to think about here. Infertility is considered a trauma or major life crisis, and it can have a huge, overwhelming impact, both physically and emotionally for women. And it can really, it can affect their marriage, it can affect their sex lives, interpersonal relationships, their careers. Financially, this can be a huge burden as well. A lot of insurance companies aren't very good about reimbursing for anything that's related to infertility. So I even just think about that with my billing codes. We might be doing our primary workup for infertility, but if I'm noticing say I want to test her thyroid, if I'm noticing she's got a couple other symptoms that could be chalked up to a thyroid, then if I can bill it under that, then at least it can get covered. And if we do find that she has a thyroid issue, then certainly insurances should be covering that. So say she's also coming in with fatigue, etc. Then if you can bill it under fatigue for the lab, then the lab will be a lot more likely to cover it than if you're billing it for infertility. So just a little bit of mindfulness around that is helpful. I'm not asking that you guys be pursuing insurance fraud or anything, but especially when we're trying to figure out what's going on, sometimes what's going on is very much something that an insurance company would be ready to help with. So just awareness around that, and then just to be aware that emotionally this can really take a toll. So helping women get set up with counseling if it looks like that would be helpful for where they're at. And also just providing a little bit of normalcy around how they're feeling. So I put here that irritability, withdrawal, numbness, hypersensitivity, just to let them know that they're not alone, and that it's common to have those kinds of feelings when they're going through a life crisis like this. So, all right, and then I've got some resources or references for you there if you want to look those up. Otherwise, I think your book covers this topic really well this week as well. All right, have a good week, everyone. Feel free to post questions to the general forum or email me. Okay, bye.